Are you loving it? Yeah, you know I'm loving it.
So if you love it and you can't get enough of it, then put the hand up high right where the other is.
Are you loving it? Yeah, you know I'm loving it. Are you loving it? Yeah, you know you loving it.
So if you love it and you can't get enough of it, then put the hand up high right where the other is.
Are you loving it? Yeah, you know I'm loving it. Are you loving it? Yeah, you know you're loving it. And if you're loving it, you can't get enough of it, then put a hand high.
Hey, this is Dr. K from the medical school, and today we're going to talk about lipid management, basically how to treat a patient's good and bad cholesterol with diet, lifestyle modifications, and medications. The overview for today's lecture includes understanding the risk factors for coronary heart disease, understanding the secondary causes of coronary heart disease, looking at the non-pharmacological treatments, as well as looking at the pharmacological treatments. We'll also be talking about the goals that you should be setting for good and bad cholesterol in your patients depending on their risk factors. So speaking of risk factors, the risk factors are categorized as modifiable and non-modifiable, which is important because there's certain things you can change about your patient or your patient can change about themselves and some things they can't. But it's important to assess risk factors in all your patients that you're considering that may have coronary heart disease, because the risk factors predict risk in 90% of coronary heart disease patients. So again, it's vital to assess risk factors in every patient who you think may have some underlying coronary heart disease. So starting off with non-modifiable risk factors, they include gender, males being predisposed to coronary heart disease over females, age, males greater than 55 and females greater than 65 are predisposed to coronary heart disease, and family history. Does mom, dad, brother, or sister have history of heart attack, stroke? Also, do they have history of risk factors for coronary heart disease like high blood pressure or diabetes? All very important to note because these are non-modifiable risk factors for your patient. The modifiable risk factors, or the factors you can change about your patient, are 1. Smoking, 2. Diabetes, 3. Hypertension or elevated blood pressure, 4. Elevated total cholesterol, 5. Elevated LDL or bad cholesterol, or 6. Low HDL or low good cholesterol. These are all things you can change about your patient or your patient can change about themselves. So in considering risk factors for coronary heart disease, what has the most significant impact on coronary heart disease risk? Hands down, it is smoking. Smoking reduces the age of symptomatic coronary heart disease by 10 years, a complete decade. Patients will bargain with you that what if they reduce smoking? Will this decrease their chance? No. It is complete cessation or completely stopping smoking, which is the only thing that will reduce their chance of developing a cardiac event. In patients who you suspect have coronary heart disease, we always calculate a Framingham risk score on each visit. Framingham risk score is a complicated equation. You can find it online and simply input the basic numbers it requires. But it basically predicts the probability of developing a coronary heart disease event in the next 10 years. And I like to stress next 10 years because this really drives home to patients that they can develop a heart attack within the next few years if they continue doing the habits that they have and eating the way they eat. Other secondary causes of dyslipidemia are important to note as well. So one would be diabetes as a cause of dyslipidemia. You can screen this easily by obtaining a hemoglobin A1C or a free flat fasting glucose. 2 would be hypothyroidism, which you can check with the TSH. 3 would be obstructive liver disease. You can get a hepatic function panel or liver function test to look for that. 3 would be chronic renal failure, so you can check a Chem6 and look at past history to note if they've had renal failure in the past. Nephrotic syndrome, so if they have any swelling or they have a lot of protein produced on a UA, then you can get a 24-hour urine protein to assess if they have greater than 3 grams in their urine. And finally, drugs, steroids and contraceptives, which you can easily look at the med list. Next, it's important to note the coronary heart disease risk equivalence because these determine the goals for the patients in terms of good and bad cholesterol. They are diabetes mellitus, peripheral vascular disease, carotid artery disease, and abdominal aortic aneurysm. The presence of any of these indicate that the patient has a high risk already of developing coronary heart disease, and their good and bad cholesterol should be managed and looked at very closely upon each visit. So the Framingham risk score predicts the probability of coronary artery disease event in the next 10 years. Calculated in patients who have greater than 2 risk factors for coronary heart disease without any risk equivalent, coronary heart disease risk equivalent, like diabetes or peripheral vascular disease. Patients who have a risk score of less than 10% are at moderate risk, 10 to 20% are at moderately high risk, and then greater than 20% have very high risk. Using the Framingham risk score, you'll determine your goals for your patient. So the treatment of dyslipidemia always starts with diet and lifestyle modification before actual medication. You want to limit your fats, limit your cholesterols, limit your salt intake, limit alcohol because it increases triglycerides, eat fruits and vegetables, eat grains, and if you can, eat fish, at least 2 servings per week for omega-3 fatty acids. The most important class of drugs you need to know for dyslipidemia are statins. Statins are medications that inhibit the HMG-CoA reductase inhibitor, which is the enzyme involved in the rate-limiting step of cholesterol synthesis. Statins lower LDL, they lower triglycerides, and minimally raise HDL. The main side effects of statins are myopathy, which is muscle pain, and hepatitis, liver inflammation. You can check these by 1, obtaining a CK level in your patients, creatine kinase level in your patients, 2, doing LFTs, liver function test, or hepatic function panel. But usually I just get an ALT because it's a lot cheaper for my patients, and by that I can check if the patient has developed hepatitis. Examples of statins include simvastatin, such as Zocor, Lipitor, atorvastatin, Crestor, otherwise known as rosuvastatin, pravastatin, otherwise known as Pravachol, and lovastatin, otherwise known as Mevacor. These are your principal drugs you'll be using in controlling patients' bad cholesterol. Second class of drugs is the bile acid sequestrants. They bind bile acids within the small bowel. Because our body needs bile acids, it takes cholesterol and creates bile acids from that, so decreasing your cholesterol. So the effects, it lowers LDL, really has no impacts on your triglycerides, and very small increase on HDL. They're commonly used in conjunction with statins in patients who are not well controlled. Some of the side effects include bloating, diarrhea, and GI upset, which can be a lot more common than one would think. They should not be used in patients with very high triglycerides of greater than 400. The most common example of bile acid sequestrant is cholestyramine. The third class is nicotinic acid. Nicotinic acid inhibits free fatty acid mobilization from tissues. It has a moderate decrease in LDL. It specifically causes conversion of small particle LDL to large particle LDL. There's actually a study done that showed small particle LDL was found to be the culprit in deposition of cholesterol into the coronaries versus large particle LDL. So creating this conversion is believed to think that this will decrease the amount of coronary artery cholesterol deposition. Cause a large increase in HDL, decreases triglycerides, but has side effects of flushing, but they can be treated with aspirin and extended release nicotinic acid. For the treatment of dyslipidemia, you can also use fibric acids or fibrates. They increase fatty acid oxidation, which causes decreased lipoproteins and triglycerides. The effects are decreased triglycerides, decreased LDL, and increase in HDL. Side effects include myopathy, and they should not be used. Fibrates should not be used with any statins because it's increased with myopathy. The most common use or example of fibrate is Lipid. Finally, again to our last most commonly used for dyslipidemia is omega-3 fatty acids. Unclear mechanism of action, it lowers triglycerides, but has a side effect of fishy taste in the mouth, commonly given over the counter. Then we have something called acetamide. It inhibits intestinal absorption of cholesterol. It's very infrequently used. I don't think I've seen any patient who's actually been on acetamide so far in my practice. Minimal effect on HDL, not a first-line agent. There's no good evidence for use as a primary drug, as evidenced by the ENHANCE trial. You can consider in patients who are not controlled with statins and other medications, but it has no effect on carotid intima media thickness, which was believed to be a marker for developing coronary heart disease events. So it's not a very good drug, doesn't improve morbidity and mortality for patients, so don't really consider it for your patients as a primary drug. In terms of goal LDL, the goal LDLs are based on coronary heart disease risk equivalence and risk factors. If a patient has a coronary heart disease risk equivalent or coronary heart disease, automatically the LDL should be less than 100 with optional less than 70. If risk factors are greater than 2 with a Framingham score greater than 20%, you want the LDL less than 100 with optional less than 70. Risk factors greater than 2 with a score of 10 to 20%, LDL should be less than 30, optional less than 100. Risk factors greater than 2 with a Framingham risk score of less than 10%, LDL should be less than 130. Finally, if it's 0 to 1 risk factors, their bad cholesterol should just be less than 160. For goal for your total cholesterol and triglycerides, these are kind of general goals. Total cholesterol should be less than 199 for those over age 21. Triglycerides should be less than 150 generally. Make sure your patient was fasting for their lipid panel, just because your triglycerides may be elevated if the patient doesn't fast. Now let's talk about the first practice case. So this is a 54-year-old male, past medical history of diabetes mellitus type 2, which is uncontrolled, hypertension, and COPD. Presents to a clinic for a new patient evaluation. He has no real complaints at this time. He knows his average preprandial glucose in the morning is 250, currently takes Lantus 8 units at night, and denies any episodes of hypoglycemia. Past medical history was as stated. In addition, he has hypothyroidism. Past surgical history is cholecystectomy and abdominal hernia repair. His family history of colon cancer, father diagnosed at age 55. Smoking history, a 30-pack year smoking history, but quit. In terms of his vitals, only thing really significant, blood pressure is 150 by 90. Cardio exam was normal. Respiratory exam just shows a prolonged expiratory phase, which is consistent with his COPD history. And then on his lower extremities, he has decreased vibration sense in the right lower extremity and no monofilament sensation on the right foot, which is concerning your diabetic patients. So what should be the workup of management for this patient? I'll give you some time to think about it. Scroll back to the previous slide and pause here if you want to kind of figure the answer out on your own. Otherwise, we'll go ahead with the answer now. So things to consider: 1, the patient has hypertension. You want to make sure that you obtain a chemistry before starting any medications. TSH, patient's hypothyroidism, could be a cause of his symptoms of hypertension as well. So check a TSH. Check a lipid panel. It's just normal screening. Anyone who's greater than 20 years old should get at least every 5 years, and then after 30 years, should get pretty much every year. Given his blood pressure is up, he has a history of diabetes that's uncontrolled. You may want to consider an ACE inhibitor on here because it's also renoprotective for diabetic patients as it decreases proteinuria. Given his father has had a history of colon cancer at age 55, you definitely want to consider colonoscopy in this patient because it's 10 years prior to his father's developing colon cancer. He has diabetes. You want to check an A1C to see how well his glucose is controlled, as well as every year he should have a urine microalbumin to check how much protein he's spilling in his urine. Again, the ACE inhibitor would help with that fact as well. Other things to consider: he's diabetic, as stated before, so you always want to consider podiatry if you can afford it, and to see an ophthalmologist as well for an eye exam. I would also consider increasing his Lantus by 4 units to decrease his preprandial morning glucose. In terms of his lipid panel comes back and shows total cholesterol of 230, an LDL of 130, HDL of 40, and triglycerides of 180. What will be the next step in management? Well, we know he has diabetes and hypertension, so he has at least 1 coronary heart disease risk equivalent. His LDL goal is now less than 100 with an ideal less than 70. So I would always do diet and lifestyle modification, but if that fails, I would definitely go to a statin such as a torvastatin. Remember, always check an ALT or a liver function test and a CK, and definitely screen for myositis/myopathy symptoms every time the patient comes in. So just a quick recap. Remember to assess risk factors in all your patients you're considering who have coronary heart disease, and assess their Framingham risk score if they have no CHD risk equivalence, so that you can identify what their goal should be in terms of their good and bad cholesterol. Diet and lifestyle modification are always your first step, and then go to medications. Specifically, statins are usually the first line medication we go to unless there's a contraindication. So this is Dr. K from iMedical School. If you like this video, give it a thumbs up, comment, subscribe. Follow me on Twitter at iMedical School. I'll see you.